Hello everyone, welcome to our channel Cancer Surgery Masterclass. Today our lecture will be about surgical treatment of renal cancer. Since there is little role for adjuvant therapy, surgery remains the only option for curing localized disease. Before we talk about the two surgical options, let us recall some surgical anatomy of the kidneys. The slide shows you the anatomical arrangement around the renal hilum. The anterior-most structure is the renal vein, which in most cases completely obscures the renal artery. The artery, which is posterior to the vein, divides into branches which enter the hilum anterior to the renal pelvis. The next slide shows important vessels around the kidney, which must be dealt with during the dissection. In the figure, CT stands for the celiac trunk and SMT stands for the superior mesenteric trunk of the aorta. On either side, numbers 1, 2 and 3 represent the superior, middle and inferior suprarenal arteries respectively, which supply the adrenal glands. The most important anatomical point of interest is the right suprarenal vein marked 4R. Unlike the left side, the right suprarenal vein enters the main body of the IVC directly and is therefore a very short vessel. Disregarding this point might lead to torrential caval bleeding during radical nephrectomy or adrenalectomy on the right side. Following laparotomy on the right side, one can see that the kidney is completely covered by the liver, pylorus of the stomach and the hepatic flexure. Mobilizing the hepatic flexure of the colon and lifting the liver up reveals only the lateral half of the kidney, since the medial half is completely covered by the duodenum. To expose the anterior surface of the entire kidney, one needs to mobilize the first and second parts of the duodenum medially or cohorize, as it's popularly known. On the left side, the structures immediately anterior to the kidney are the splenic flexure of the colon, the spleen and the tail of the pancreas. The splenic flexure is mobilized inferiorly by splitting the splenocolic attachments. The spleen and the tail of the pancreas is mobilized superiorly and medially to reach the bare surface of the kidney covered by Gerota's fascia. This slide shows the soft tissue arrangement around the kidney. On either side, number 1 stands for pararenal fat. Number 2 represents Gerota's fascia, which is the fibrous capsule which completely covers the kidney and fuses medially with the vascula adventitia. And number 3 stands for prerenal fat, which is outside the renal capsule. First, let's talk about radical nephrectomy, which used to be the standard treatment for all renal cancers. Radical nephrectomy is en bloc removal of the kidney and the ipsilateral adrenal gland with intact Gerota's fascia. Let's look at the indications for radical nephrectomy. A malignant lesion that is larger than 7 centimeters in diameter. A larger lesion close to the hilum with a contralateral normal kidney. Multifocal lesions of any size with a contralateral normal kidney. Ipsilateral recurrent disease. Major vein involvement. Extrarenal soft tissue deposits. Involvement of Gerota's fascia. And finally, regional or distal metastatic disease. First comes exposure. We prefer open surgery since larger lesions need bigger incisions for retrieval and smaller lesions need nephron sparing surgery. We do not have robotics to perform minimally invasive nephron sparing surgery. The first step is to dissect away all the anterior relations beyond the level of the renal hilum to expose the major renal vasculature. The kidneys mobilize posteriorly through the pararenal fat up to the level of the posterior part of the hilar structures. This makes the surgery easier since the kidney becomes mobile. We then continue the dissection inferiorly around the lower pole of the kidney up to the lower border of the hilum and divide the ureter and ligate both ends. The superior dissection is continued over the adrenal gland up to the superior border of the renal hilum. The adrenal vessels found along this path must be divided and secured. Now, the only attachments of the kidney are the vessels. The artery must be controlled first before dividing the vein to avoid congestion of the kidney. Due to the posterior location to the vein, it may not be easy to ligate and divide the artery before the vein. Therefore, placing a clamp across the artery prior to division of the vein is an easier alternative. The second surgical option is nephron sparing surgery, which is the standard treatment for renal cancer except those that need radical nephrectomy. Nephron sparing surgery is commonly done after clamping the renal vessels to minimize the risk of torrential bleeding. This surgery possesses two challenges. First is performing the surgery within 20 minutes after clamping, since the safe warm ischemia time allowed is 20 minutes. For bigger lesions, packing the perirenal area with crushed ice can be done to buy time. However, trying to perform heroics may lead to a dysfunctional kidney with major bleeding and reoperation. Therefore, one must not hesitate to go for a radical nephrectomy in tumors which are more than 7 cm in diameter or tumors in more central locations. The next challenge is to avoid renal fistula after complex resections. We recommend two kinds of resections: polar resections for large polar lesions and wedge resections. We do not recommend enucleation since it is not standard to do routine histology prior to the resection. We treat each lesion as a malignant lesion. Around 97% of renal cancers possess a fibrous pseudocapsule which is devoid of any malignant component. In 60% of instances, this capsule is completely formed around the tumor, especially in clear cell renal cell carcinomas. In non-clear cell renal cell carcinomas, this fibrous capsule is partially present or rarely completely absent. As the tumor grows beyond 2 to 3 centimeters in size, the capsule tends to get breached. In 97% of tumors, 4 centimeters or less in size, even when breached, malignant cells cannot be found more than 3 to 4 millimeters beyond the level of the capsule. Therefore, for tumors less or equal to 4 centimeters in diameter, we advise a 5 millimeter macroscopically clear margins, and for larger tumors, a margin of 1 centimeter. Tissue approximation is not essential, since in some cases it is impossible. But careful approximation of the collecting system is essential to prevent a urinary fistula. We hope this video has taught you some valuable tips regarding renal cancer surgery. Thank you for watching.